I think it's good to be on mute till we get a chance to speak, just to make sure the audio is not distorted. Thank you. Good afternoon, everybody. Welcome to the series on Telearogya on OSCEs. I'm just giving another 2 minutes for the students to join in. Just be on hold. We're all just going to give it some more time and then we're going to begin. Thank you. We have around 50 participants still counting, so there's still some people logging in. I'll just wait for 1 more minute. I think we should begin. Once again, good afternoon and welcome to the training series on OSCE. Today we have two distinguished colleagues from NIMHANS joining us. Firstly, I would like to welcome Dr. Shyam Sundar, who is the Additional Professor of Psychiatry at NIMHANS. We also have Dr. Lavanya Sharma, who's a Senior Resident at Department of Psychiatry NIMHANS. Welcome to both of you, and thank you for agreeing to do this sort of mock drill on the students today and set up a context for evaluation. I also thank Dr. Manan Joshi and Dr. Vivek Dave, who agreed to volunteer and be a part of the process of evaluation today. Dr. Shyam has actually meticulously prepared a few manned OSCEs and how this sort of evaluation process can happen. So they've worked meticulously hard over the last 2 days to make sure the volunteers knew what is expected, and they've actually monitored the whole case scenario process. And NIMHANS has been of immense help for us because they have a first-hand experience of doing manned and unmanned OSCE, and this sort of testing was implemented for the first time at NIMHANS this time. And Dr. Shyam and the HOD of the Psychiatry NIMHANS, Dr. Pratima Murthy, were actually offered a good helping hand to set up this sort of training program. Over to Dr. Shyam and Dr. Lavanya.
Anyway, okay, thank you, Dr. Mahesh. So, welcome to all of you to this mock exam. So, what we'll be doing today is, I think till for the past 3 sessions, we've been having unmanned OSCE, where the questions came in the screen and you had to answer it. Now it will be more like a live performance, just like any clinical examination. The only difference is that you might be asked to do it on a simulated patient rather than a real patient. So we don't know the exact format in which DNB expects you to do, but this is what we did this year at NIMHANS. So we'll be practicing it over here. So two people have, Dr. Vivek and Dr. Manan have volunteered. So we'll have at least 2 scenarios in which each one of them will be a simulated patient. Then we'll be asking the other person to, we'll be giving a case scenario, and the other person has to interview on a particular aspect or interact with the simulated patient on a particular aspect. It could be something like explaining the side effects of a particular drug or psychoeducation about something. It could be anything. We'll be coming to that. So in this, basically, here we have said that we'll say that the time given is for you is 10 minutes. So when we start, first, Dr. Lavanya will be reading the scenario to you. She will be showing the scenario in this over the slides. And after that, you will have a time for 10 minutes in which you can do the interview. Dr. Vivek, I think you are doing the first interview, right? Yeah. So, so one thing is that, so the information has already been given to you. You need not go into eliciting history as from the simulated patient. You can focus on the particular aspect which you are asked to interact. But as in any clinical encounter, it's better to first introduce yourself, keep the patient comfortable, and like you do it like any other clinical interview. And at the end, it's better that you conclude the session. And in between, it's better that you make sure that the person has understood it, paraphrasing and repeating and sort of things can be done. So yeah, but there's no need for eliciting a lot of history in this aspect. Okay, so we'll have 10 minutes. I think the time will start after Dr. Lavanya reads out the question. And then after the 10 minutes, people who want to ask questions can ask the questions after the OSCE is over. Otherwise, it will be disturbing for the person doing the examination. So after the 10 minutes is over, then we can open the session for a discussion. You can type the questions or Q&A. Okay, is it clear?
Yes.
Okay, thank you. Lavanya, I think you can.
I'll start, sir. Yeah. Right. Can everybody see the slides?
Yes, Lavanya.
Okay, great. So, right. This is our first scenario. A 33-year-old female with bipolar disorder has recently remitted from a manic episode, which was treated with olanzapine up to 20 milligrams per day. The patient has had 2 episodes of mania in the past. You plan to start her on lithium. Explain to the patient regarding the side effects of lithium, monitoring for adverse effects, and precautions while on lithium. Maybe they can go ahead now, sir.
Yeah, they can go ahead. Dr. Vivek, you can start.
Yeah, hi.
Excuse me, can we stop sharing the slides so that we can see Dr. Vivek? Yeah, Dr. Vivek, you can go ahead now.
Yeah, hi. Can you listen to my hello?
Yes, Vivek. Yeah, audible. No problem.
Yeah, okay. So basically, as we know that we have reached to a diagnosis of bipolar disorder, which is mood disorder. It has 2 poles, that is depression and mania. And in your case, basically, we have had past episodes of mania, and which was treated with olanzapine, which is an antipsychotic drug.
Yes.
This drug is also used for stabilizing mood, but it also has some of the side effects. Now, the 3rd episode has come. This episode of mania is to be treated at present, and I'm planning to start a new drug, which is called as lithium.
Okay.
It's basically a mood stabilizer drug, and it has a very good property of basically decreasing the number of relapses, plus decreasing the severity of the relapses. Like if we start using lithium, the drug, the probability of future episodes that might occur, and the severity which might require hospitalization, that would decrease. But basically, before starting this drug, I would like to clarify some of the points with you. Basically, this drug has it has a narrow therapeutic index. Like we need to monitor it regularly. Say for suppose if I am starting the dose, send 1 tablet at night, and basically I'm building it up twice a day. It has to be taken under supervision. Second thing, it has got some side effects like neurological side effects. There are common side effects and neurological side effects like Common side effects like there is fine tremors, there is lethargy, there is mental sluggishness, the thoughts are becoming a bit slow and you feel like you are very lethargic. Plus, there might be some skin eruptions for which you need to take care. If you have any problems with allergy, there is psoriasis that might flare up. So that you need to remain aware about. Apart from this thing, it also affects kidney functions because it in body gets concentrated in the body, especially when you are dehydrated. Dehydrated. So always you need to take care that you are drinking enough water, you are hydrated enough. If suppose you are developing, say, like diarrhea or say vomiting, and you're not feeling okay, you need to see a doctor so that this lithium side effect does not increase and it does not have an effect on the kidney. Basically, it gets concentrated into the kidney and can lead to toxicity, which might further end up into renal failure, and you might need to go under hemodialysis. So we want to prevent that. So basically, you need to be aware about that. Apart from this thing, if you are religious enough, you are planning to keep some fast, which is very rigorous fasting, like you don't drink water. So in that case, you need to be careful about so that the side effects are not there. Okay. And I would be prescribing this tablet in a BID dosage. No, sorry, at night. I'll be starting this at night. And after, say, 3 to 5 days, we'll be increasing the dose twice a day. And after 1 week, we will be monitoring your blood levels, like serum lithium levels. Basically, it is the lithium which is building up into your blood and into your serum. For that, you need to get your test done early in the morning before the dose is being taken. Any dose is being taken. Like there should be last dose, 12 hours gap between the last dose and the next dose that you are taking. So basically, after looking to that, we can, and basically all the symptoms, we could further decide whether to further build on this lithium or not. And also we need to monitor side effects, as I told you, like tremors and everything. So basically we need to take care about that.
So for how long will I have to continue this medication?
See, bipolar illness is a recurrent illness. It reoccurs in episodes. It might have its severity. So basically you need to take it continuously. As you know, there has been history of previous 2 episodes. We don't want it further. We don't require hospitalization in future. So to prevent that, I would suggest that you continue with this medication at least for 4 to 5 years.
All right, sir. Sir, will I be able to continue my daily routine like I am working as a teacher? Is it possible to continue my duties when I am on these medications?
Yeah, definitely. But the thing is that the side effects, you have to take care about it. If the side effects are developing, you should contact us immediately so that we can modulate the dose so as the side effects won't hamper your day-to-day functional occupation.
Okay. Will there be any dietary modifications I should be doing while being on this medication?
Yeah. You need to take care. That's a very good question. You need to take care about your weight also, because lithium might increase your weight. So basically, you need to keep an active schedule. You may do some exercise, or so go for walking, or so avoid all the sweet and oily food, so that would not increase your weight over the period of time.
Okay. Sir, what are the chances that my offsprings, in case if we are planning to conceive, what are the chances my offsprings may have this illness?
Sorry?
And what are the chances that my future babies, or if we are planning to conceive, they may also have chance of having this illness?
That's a nice question. If you are planning to conceive and you are planning for a child, this medicine needs to stop because it has a side effect. Congenital malformation of the heart in the child. So the risk is high, and we would not like that to happen. So we need to then change the medication, or we basically we should, if I would want to ask you, like, how many children do you have right now? So we can also go for a family planning. If the family is completed, we might not want the another child, or basically you might also adopt a child if you want.
Okay. Okay. Sir, is there any other modalities available for treatment of this disorder?
Yeah, there are.
In case if I want to plan for shifting to some other sort of modalities rather than medication, rather than pharmacological treatment.
Yeah, other modalities in the manic phase, basically it would require, if the symptoms are severe enough, it may require hospitalization. If the levels of aggressions and the agitation is so much, electroconvulsive therapy could be used. Apart from that, there are injectable and non-injectable drugs like antipsychotic and benzodiazepines, which would control the symptoms of mania. And that wise, it could be used. Apart from lithium, there are other mood stabilizer drugs that could be used, or we might also use second generation antipsychotics, which has very good mood stabilizing property, which would be even safer in terms if you are planning to, if you are having any ideas of family, expand your family and conceive a child.
Okay, all right.
Any other questions?
Is there any other precautions needed if I want to reduce the frequency of further relapses? What are the other cautions should I take?
Yeah, other cautions, basically, you need to first understand about this illness. Basically, this is a mood disorder which requires medication for a longer period of time. If someone who is on medication and who is complying with the dose, with the advice of the doctor, so the chances of relapse will be lesser. However, even if the symptoms do occur, one should not waste time, and you should see your psychiatrist as soon as possible. There are also other long-acting injectable drugs which are used, which would ensure compliance in the patient. That would also prevent further relapses of symptoms in the case of bipolar disorder.
Okay. Okay. Sir, is there any particular caution I should be taking if I am taking other drugs with this medication?
Yeah, basically, this drug will it has a bit sedating effect. Plus, there are certain drugs which are contraindicated with this, like there are diuretic group of drugs, so thiazide diuretics, loop diuretics. Apart from that, over-the-counter drugs like NSAIDs, like painkillers that you take in your day-to-day life, like diclofenac or say ibuprofen or any other NSAID group of drugs. So you need to be careful about that. That might increase the lithium concentration in the kidney and ultimately lead to toxicity. So you need to be careful regarding that.
Okay. Okay.
The time is up.
Okay.
Yeah. Thank you, Dr. Manan and Dr. Vivek. It was a very nice interview. So people now can post their questions about the interview itself. And if you have any questions on how to go about it. Before that, I think we would like to discuss a few issues.
Yeah.
Lavanya, would you like to start?
Yes, sir. It was good that you kind of said that, okay, you have a diagnosis of bipolar disorder. So you actually started off by summarizing the information that was already available. Just to add to that, in the initial part, when you're starting the interview, even though you have some information already, it might be a good idea to kind of talk about things like why you're meeting today. So I'm meeting today because I wanted to discuss further therapeutic strategies with you, or what medication we could possibly start you on. Okay, that would be one thing. Another thing that I would want to talk about would be confidentiality, which is very important. So things like, whatever we discuss right now will remain confidential between us. unless, there is something that we feel puts you at risk or puts others at risk, in which case we might have to disclose. So that is something that is very important. And third, assessing comfort. So are you comfortable right now talking about this? Is it okay? Can we continue with the conversation? So once you have that, then maybe you can proceed with the rest of the interview, right? This will be the initial things. In terms of, one thing that I may have done differently would be probably I would have checked the patient's understanding first. So rather than jumping in by saying, this is the thing, you have this, this is. So can I just understand from you what you understand, what you have understood about your illness, about medication and all of that. Ask if she has any doubts, if she has experienced anything with regards to this medication. Technical sort of jargon may be difficult to follow for a lot of patients. So unless your patient is somebody who's a medical professional or something, they may not understand things like therapeutic index, right? So I would say that, when you give this medicine, it needs to be given at a dose so that a certain level, a certain range of blood level needs to be maintained. So I would have to titrate it accordingly, so we may need to monitor for that. Okay. Other than that, I would also want to assess understanding repeatedly, particularly because you're giving her a lot of information and you're talking a lot about side effects and things that can be potentially scary for someone to hear. So I would want to say, okay, fine, have you understood? Can we move forward? Okay. Or I would want to keep summarizing at different points by saying, okay, that is one aspect of it. I also want to talk about this next thing. So it went all over, I don't know, it went into risk of renal failure and dialysis and all at one point of time. I don't know, were you talking about lithium toxicity at that point? Or?
Yeah, ma'am. Like if in future that could be the
nephrotoxicity with lithium, I think it's what you've been.
Yeah, because actually the proportion of people who progress to end-stage renal failure is very low with lithium, chronic lithium use also. Although they may develop stage 1, it may not happen that way. But anyway, yeah. Other than that, yeah, you asked about medication interactions and things like that, which was good. I would have, in addition to talking about lithium level, I would have also talked about looking at baseline TSH, urea creat, calcium, electrolytes, weight, BMI, the usual things that you would want to monitor, and tell them how frequently they need to check these things. Every 6 months you need to check this, 2 months this, next subsequently this, right? Because that is something that they'll have to do regularly. I would want to spend a little more time talking about those things. Other than, I think in between you talked about ensure compliance in the patient. The patient is in front of you. I would not refer to her in the third person. Right? So say that, if, for example, a person is finding it difficult, if you're trying to use it as an example, you'd say, if, for example, somebody is finding it difficult to take medication or refuses to take medicines or something like that, this is also an option. Anyway. Other than that, I generally, one would not suggest to the patient that, you adopt rather than you take lithium and conceive, okay? Because actually, if you look at the risk of Epstein's, it is almost 1 in 2,000 exposed this thing. So that's not a high risk really, okay? That said, there are other options also when somebody is planning to conceive. If they're a little, you explain the risk to them, you explain the absolute risk, and then you say, okay, there are other options that we can also discuss, but it's possible that you need to be on some medication or the other. I would not, give them the option of adoption or this thing. That is their decision to take. Your thing is just to provide the info. What do you think, sir, other than that?
Overall, as you said, it was like a interview with the baseline and sort of things. Yeah, one thing somebody else has asked in the question also, you might have introduced yourself. You can introduce yourself before starting the interview. So in OSCE, there are 2 parts. One is the content of interview is one part. The other one is the other general aspects. There, things like introducing yourself, that comes. And like Dr. Lavanya said, ensuring confidentiality, just a statement that would help you in scoring points in the OSCE. And other thing is intermittently in between, because you're sharing a lot of information, you can just check with the person, whether the person has understood it or so, those things also can be done. And at the end, you can also, like in certain circumstances, you can ask them to summarize what they have understood and what do they feel about it. Because I haven't explained everything. So what do you think? Do you like to start the person? Do you like to, shall we start on lithium or something like that? That might have done. So, yeah. So explaining the whole understanding from the initial part might not be required in this context, but at the end, you can ask the person to summarize what they have understood. Now, coming to the content of the interview, you have explained most of the side effects. So one thing is that I would suggest that you can sort of categorize it in your mind. You can differentiate it into something like acute side effects and long-term side effects, so that it will be easier for the person to comprehend also, and it's easier for it will be also easier for you. It will make sure that you also don't forget what you're going to explain. And when you spoke about the side effects, especially the dangerous side effects like nephrotoxicity and sort of things, it might be better to contextualize it in terms of, renal toxicity is a possibility with lithium, but the chances are it's very rare, and it usually happens over long-term use. And it is for that reason we are going to test your renal function tests every 6 months. Okay. And if there is a suspicion that there's any problem with the renal function test, we will immediately stop lithium. Okay. So you can provide a context to that. And similarly, regarding pregnancy, you can say that lithium is associated with the Epstein's anomaly and various other aspects also. Like, for example, during pregnancy, as the body fluid changes, lithium levels might fluctuate, postpartum the levels might fluctuate, breastfeeding is contraindicated. All these issues are there. All the like Dr. Lavanya said, the chances of Epstein's anomaly is not very high, 1 in 2000. But still, with all these side effects, we might have to discuss whether we have to continue lithium or not. So the first thing is, before you think of pregnancy, you have to come and discuss with me. You have to plan the pregnancy. It should be a planned pregnancy, and we can decide regarding lithium beforehand whether it's required during pregnancy or should be shifted over to some other medication. Okay. So you make sure that everything is being taken care of. That sort of things can be, And one important thing is in the content, the most important thing which I missed was the lithium monitoring, expected renal function test and TSH levels at least to be told every 6 months. Okay. These three at least, serum lithium, TSH and creatinine at least should be told, ideally. And apart from that, other things like calcium, parathormone and sort of things, those are additional tests, electrolytes. But these three should have been there in the interview. Okay. I think these are the main things. Technical jargon can be avoided. Try to use as simple as a language. I understand because it's an anxiety-provoking situation. But maybe what all of you can do is you can practice among each other such scenarios with common drugs like lithium, clozapine, or some other drugs, and any other some other situations, psychoeducation regarding pregnancy. So these are some things which you can practice among yourselves so that you get used to it before the exam. Okay. And people have asked whether they have to explain in English or Hindi. This is just for exam purposes, and if the person opposite to you is a simulated patient, you can speak in English. It should not be an issue. And also, we don't have to take into consideration the mother tongue of the language that is comfortable for the examiner also. If it's a real patient, all these things come into place. You have to speak in the native language of the patient. But if it's a simulated patient, I think it should not matter. Okay. People have... somebody had asked frequency of lithium testing, and every 6 months, I think that was there. Congenital anomalies have to be explained. Explain the action of the necessary mechanism of action of the drug that might not be required for the person. If the person asks, you can say, and because for most drugs, we also don't know exactly how it works, so it might not be required.
Asked, sir, if after the interview, if the patient rejects lithium, how to manage?
You have to respect the decision. And you have to give the Another option you can consider is, if you have time, you have to why you chose lithium among the different drugs. That is something which you could have discussed. For example, there is valproate, as you said, there are atypical antipsychotics, quetiapine. Among these, why did you choose lithium? That would help the person decide whether to continue lithium or not. Lithium, as we know, is the most established mood stabilizer, and it has more evidence across all phases of illness. So in that way, we thought lithium might be the drug. Yeah, but if you feel after all these things, if you the person is not willing, then you can provide the alternative. What are the alternatives that are available? Second option may be quetiapine or something. In this patient, it's a female patient, right?
Yes.
Yeah, I think we should not have. We should not speak about valproate. We should be remembering that because the teratogenic density is very high with valproate, around 8%, I think, compared to lithium. So in that way, yeah, quetiapine or something can be discussed in this. Yeah, you can discuss. You have to respect the patient's decision. So how you keep the person comfortable is also important, and you have to respect the patient's decision and help. These things are also important to interview. Yeah. So somebody has asked, yeah, 1 in 10,000. Yeah, it's 1 in 2,000. The in general population is 1 in 10,000. In people on lithium, it's 1 in 1,000 to 1 in 2,000 sort of thing. It's very rare. It's not that high. But the thing to remember is that lithium Epstein's anomaly is a very serious anomaly. That is the only thing. And as I said, there are other aspects of lithium also which has to be kept in mind before prescribing lithium during pregnancy. So those things can be discussed. Yeah, you might not have time to discuss everything. So you discuss how much ever is possible, and you can ask for the questions further.
One way of asking about this drug interactions and all would be to ask what pre-existing medical conditions that person has, and then are they taking any other medication, and then say the reason I'm asking this is because lithium can interact with certain medications and they can increase the levels of lithium, like whatever, certain kinds of diuretics and so on. So if the person has a history of hypothyroidism, yeah, you can get it there.
Yeah.
So when the OSCE has been like, or the manned OSCEs have been given in the exam, you need to take a brief history, because I cannot suddenly jump on the thing that, I can directly not start with the side effects, and it doesn't come in a flow, because this was for the first time that happened. So, sir, do we need to take a brief history, and if so, then how much should be the time? Like 10 minutes is all that is given for one OSCE for this thing.
Yeah, so this is that is one of the more important criticisms about OSCE in general. It's a very artificial atmosphere. You'll definitely be speaking in a different way when you speak to the patient, because you know the patient. So here you are speaking to a person. It's a really different thing. But here, because in 10 minutes you have to prioritize. You can't take a history also. And what I think, if at all it happens in DNB, will be something like you might be having a passive patient, or you might be, I don't know, if it's a manic, when you imagine that this is a patient and talk to them. So it will be mostly psychoeducational, or if you'd be asked to face the screen and talk to them, I don't know. So in that, you had to prepare for these aspects also. So you can say that what you did was excellent in that way. So both of us know that we are treating this aspect of the illness.
Okay.
Bipolar disorder, and there have been 3 episodes of these types of illness. So because of which you need some long-term medicines to prevent further recurrences. And in this context, I am suggesting you this drug. So I think you brought out that context well in which you are doing it. And you could proceed from there, and you can ask the person, like if you don't understand anything, you can interrupt me in between.
Okay. Thank you.
So there are some questions in the Q&A.
Yeah, so somebody has asked whether when serum lithium level should be done. Yeah, it's about after 5 days. What you said is right, and 12 hours after the night last dose of lithium. That is how we should do the levels. Yeah.
Do we need to frighten the patient by saying renal toxicity and thyroid dysfunction?
I think we have to say it. Definitely, that's a possible side effect. You have to say it, but you have to contextualize it by saying that what is the risk. It is there, but the chances of renal toxicity is whatever I said earlier. We keep monitoring you, and chances are very less. It happens after a very long time dosage, and if it is there, we'll be treating you accordingly. All those things you have to contextualize it.
Asking about in English or in our language, I think in the exam in English. If a patient is on lithium and in remission now came for review, do we still need to measure serum lithium on 12 hours interval or at any point?
You wait whenever you do the lithium levels, you have to do it 12 hours after the levels. So, because the 12 hours is mainly for the trough levels. We are not looking at the peak levels. So immediately there'll be a peak. When it reaches the steady state level is what we want to see. That's the trough level. The only indication where you don't wait for 12 hours is when you suspect lithium toxicity, where you need to report immediately. Otherwise, you have to wait for 12 hours just for monitoring lithium.
How to make sure that the patient will be compliant after she hears side effects?
That's why you have to tell the patient these are the side effects. You're explaining to the person, and first I get the consent of the person before proceeding. Do you think that we can proceed with lithium? And we are with all these precautions. If the person says yes, then you go ahead. Yeah. So,
unless you guys have any questions, we'll go on to the next.
Dr. Mahesh is there if he wants to add anything. Okay, I think Dr. Mahesh is not there. So anyway, so now I think we can go to the next scenario. Can we go to the next?
I'll just share this link. Right, so this was the first scenario that we had. Now, this is the second one. A patient is diagnosed with opioid dependent syndrome. He has been using heroin over the last 10 years. He has had multiple failed abstinence attempts and a history of severe withdrawals in the form of body ache, sweating, runny nose, lacrimation, and diarrhea. He is not able to pursue his career as a finance consultant due to frequent disruptions in his routine because of substance intoxication and withdrawal. You plan to start him on opioid substitution therapy with buprenorphine naloxone combination. Explain to the patient regarding the rationale, nature of treatment, and precautions. Okay, so in this scenario, Dr. Manan will be interviewing and Dr. Vivek will be the patient.
Manan, you need to unmute your mic.
Hello. Hello.
Yeah.
Am I audible now?
Yeah.
Should I proceed?
Yeah.
Yeah. Hello, this is Dr. Manan. I am a psychiatrist, and I am going to ask you some questions about the problem for which you came here right now. First thing I would like to tell you is that whatever we are going to discuss here is going to be between us only. There will be strict maintenance of confidentiality between us, and there won't be any breach of confidentiality at any part further during this interview. So, may I have your consent to proceed further?
Yeah, definitely.
Okay. So first thing I would like to tell you right now is that whatever problem you are having, in scientific terms, it is known as opioid dependence syndrome, in which the person is having problems because of regular consumption of the substance like opioids. So that is the diagnosis that we are having right now. The good part is if you will maintain good compliance with our medications, if you will stay in touch with therapist, then definitely there are chances that you will come out of this situation. And there is no need to feel bad about yourself. It is a biological condition in which, because some part of genetics and some part of environmental factors plays a role, and that is the reason why this condition happens. And in terms of psychiatry, it is considered as an illness only. So there is nothing to be nothing to feel bad about yourself or to blame yourself. So first thing, please.
But why am I not able to quit? I have tried many times to quit heroin that I'm using, but I'm not able to do it.
Yes, it is a very valid question. And many of the, if I would be in your condition, then also I may have to face the same difficulties that you are facing. So I'm assuming that whenever you are trying to quit, you start having withdrawal symptoms like runny nose or headache or not feeling good or a loss of appetite, that sort of thing. And those withdrawal symptoms are the reason why you are having repeated relapses, right? So that is a very natural thing, and the medications which we are going to provide you from now will minimize these withdrawal symptoms to minimum, and will make it very easy for you to quit the drug. So first thing I would like to ask you is, do you feel that the drug you are taking regularly is the drug you are taking regularly is causing trouble to you? Is it? Are you willing to quit the drug right now?
I am willing to quit the drug, but only if it is sure that it doesn't. I do not catch this habit again, because I am dealing with this problem past many years.
Okay.
And sort of, if I say I can function okay if I am taking the drug, the problem starts since the time I quit or I try quitting my drug. So
Okay.
please solve my problem. What can I do for it?
Okay. So the first thing I would like to say is you need to be in constant touch with the therapist. There are some pharmacological treatment plans as well as non-pharmacological treatment plans for this condition. We are also going to plan a motivation enhancement therapy for you, for which you need to be in touch with the therapist, and regular sessions will be started. That will also help you to build the motivation for quitting the drug, as well as there are non-pharmacological part, like there are opioid substitution therapy, which is available for patients with opioid dependence syndrome. In this therapy, there are certain drugs that we will be giving to you, which will almost act similarly like the drug you were already taking. But the good part is it will be having less dependence potential. Like once you will start taking these medications, you will be having less chance of repeating that behavior, like less chances of having craving or other sort of unacceptable things that can happen with the drug you are already taking. It also reduces the chances of infection. It also reduces the chances of other harmful effects of the actual drug you are taking. So although it works through same mechanism, but still it is definitely a beneficial molecule which we will be giving to you. And eventually over the period of a few weeks or months, you will be able to quit the drug you are taking if you comply regularly with this medication. Another thing I would like to, yes.
Yeah, I have heard from a lot of people that these medications are also addictive. So one I am facing with this heroin problem, and again I take some medication which you prescribe, I may again be addicted to that medicine. So how can I deal with that?
Okay. Okay. So good that you asked this question directly. I would like to answer it like, see, the thing is, the drug you are taking already has very high dependence potential. To explain it further, if let's say 100% are taking this drug, there are very high chance that those people will need to take these medications repeatedly, and if they won't take it, they will start having symptoms like withdrawal and craving and everything. But the medication we are providing you right now will eventually cause less craving, less withdrawal symptoms, and will be having far less dependence potential compared to the actual drug you are taking. Okay. And eventually we will be able to taper the drug gradually, and after a period of few weeks or months, you will be medication free. So that is how the therapy works. And it works by same mechanism as the actual drug, but it has far less dependence potential compared to the actual drug you are taking.
What precautions do I have to take?
Okay, so the medication we are giving you right now is a combination of two medications. One is buprenorphine, which works same as the opioid works and occupies the same receptors, and the another one is naloxone. So naloxone is basically an aversive drug, which blocks the effects of the buprenorphine if it is taken by intravenous route. Intravenous route means if it is given by injection method.
I don't use injection route.
Okay. I agree that you don't use injection methods, but the reason why I'm saying this is because it cannot be used at all as an injection. Even if someone wishes to, then also they cannot use this drug as an injection, because the medication will immediately, the naloxone part of the medication will start occupying opioid receptors in which the actual medication works, and it will cause withdrawal symptoms if you are taking already taking any opioids. So that will lead you to be to a very uncomfortable state for you. So that is the reason why you should not or cannot take this medication by injection route, right?
Okay.
So that is a caution that you should take.
Okay. Other precautions?
Otherwise, if you are taking this medication, you should be careful about taking other sedatives because it can lead to excessive sedation, drowsiness, that can be risk of fall. That is a thing you should be careful about. If there is any other medications you are concurrently taking with this, then you should immediately report to me or any other physician you are taking medications from, like antihypertensives or other medications related to neurology, psychiatry, or anything.
Will this medication be very costly because my work is not going like properly? You know, there are job issues. So will I be able to buy it on a regular basis?
Yes, you will be able to buy it on regular basis.
Okay. So how much will it cost a month around?
I'm not sure about this, but it may cost around 1,000 rupees.
Okay, that much. Will there be any other side effects if I take it?
Yes, if you are taking this medication, then there can be once we start this medication, there is a concept which is known as precipitated withdrawal. So once you will start this medication and you are already taking any opioid medication which works on same receptors, then you may temporarily feel withdrawal symptoms like runny nose, watery mouth, diarrhea, or watering in eyes, or drowsiness, and other symptoms of opioid withdrawal that you may be facing temporarily. But if you be in constant touch with the therapist, if you are regularly visiting psychiatrist, then we can minimize it to a very low level, and you will be almost withdrawal symptom free. Is there anything else I can help you with?
I hope I don't require admission to the hospital for this treatment thing.
No, if you are regularly following in OPD, then I don't think right now any hospitalization is required.
Okay.
Another thing I want to ask at this point is that is there any other medications you are taking for related to psychiatry, or any psychiatrist diagnosed with some other sort of illness?
No, not as of now.
Okay. Is there anything else I can help you with? Is there anything else you want to ask?
And doctor, you told me about motivational therapy. Can you tell me about that? Like, what is it? I am not aware of it.
Okay. So it is basically non-pharmacological part, because medications though you will be taking regularly, but this is the other part of the therapy in which you'll be constant touch with the therapist. And there will be weekly sessions that will be planned for you, and we will regularly discuss about how you can quit this habit, how we can help you with quitting this habit, and building your motivation basically.
Okay.
Time is up now. Thank you again, Dr. Vivek and Dr. Manan, for that interview. So there are already a few questions. Before that, Lavanya, do you want to?
Sure, sir. Okay, it went off quite well. The introduction was good. Confidentiality and all of that was kind of, ensured. You took consent from him to proceed with the interview, which was nice. You started off by providing a lot of information, psychoeducating him and all of that, and validating his concerns in between when he was asking some questions. I forgot which question he asked, but I remember that you said, yeah, okay, I understand, with regards to assessing his motivation also, you tried to assess his motivation in between. So some of the points that one would want with regards to a person with opioid dependence is, first of all, their level of any substance use, basically, a level of motivation. Risk was one more thing. So the route of use, I think he told us that he does not use needles, injectable. He's not an injectable drug user, but I think route of use, needle sharing, STIs, okay, other high risk behaviors, comorbidities because of this, hepatic, other substance use would be something that you may want to touch upon when you're starting to talk to him about buprenorphine, naloxone. right? Then you started off by telling him about the pharmacological methods and so on. And I think he only led to the whole harm reduction discussion where he said, right? I think that was what you were hinting to, right, Dr. Vivek? About, I think he's muted.
Yeah, ma'am.
So you're replacing one drug with another addictive drug. What's the point, right? So that would have been a good way to say, this is how we do handle craving. The withdrawals would come down. Your risk would come down in general. Drug seeking behavior and spending a lot of time and effort and this thing on drug seeking would come down, right? As a result of which you may perhaps become a little more functional. He says that he's a financial consultant. He's not been able to work properly because of that. So it may help. So you can actually seg it into his general, his routine and tailor it to his own needs, right? And other than that, he asked you something about cost per month or something. It's okay to say, I'm sorry, I don't know offhand. I'll get back to you as soon as, maybe after this interview, I'll get back to you with the approximate, this thing. So it's okay to not know an answer. You need not get stumped and say, okay, fine, 1,000 rupees, something, I don't know.
Okay.
It's hard to keep track of all those things. So it's okay. And, precipitate withdrawal also, if he's scared of that, you can always tell him that we can manage the withdrawal phase with other medication and then start after a washout period of a few hours, 6 to 8 hours usually, then you can start and build it up according to whatever is required. Other than that, I think one more thing that we generally do, do's and don'ts you mentioned with regards to, one more thing would be like avoid other sedative hypnotic medications, avoid alcohol and things like that when you're on buprenorphine, which is one more thing that you mentioned about the naloxone, and that's why they don't powder it and you can't give it IV because then again it will, okay, that was good. Here what we do is we take a buprenorphine consent form. So there we take the written consent explaining that these are, the side effects. These are the things that I agree to do under these circumstances. I would have to be monitored and so on and so forth. So that is something. And also one thing that would be useful would be to tell him how you take it, because it is sublingual, right? So that, how it will be initially given and how you will be titrating the dose, right? What are the doses that are available? We would probably, you may, depending on your use. So there again, you can ask how much are you using, heroin, how much, what are the quantity, how do you use? And then you can say, okay, maybe you'll need around say 4 to 6 mg or whatever, or whatever it is, we'll titrate it accordingly and see. So these are the things that I would also want to include. Other than that, I think, summarizing and ending accordingly. I think that was fine. What do you think, sir? Anything?
Yeah, I think it was a good interview. I think he he started from the overall. I think the other aspects of it, like introducing, ensuring confidentiality and sort of things are okay. They can be very brief. You need not go into detailed introduction and sort of things. Yeah, what you did is okay. I think you can shortly give about all the important points and you can start for the interview. So other aspects are okay, making sure that the person understood, summarizing and everything was okay. Regarding the content, whatever you said is okay. That is the major question that will come up in all opioid substitution therapies, that's a controversial aspect, but it's not actually controversial. You can say as I said, it's a longer acting drug. So the effect will last, so multiple drug-seeking behavior can be avoided. All illegally, going through all these things, drug-seeking behavior, going out for drug-seeking. The dysfunction substance use not only because of the actual substance use, but the whole process of seeking the drug, taking the drug intermittently, disruptions, all these things will come down. And also the chances of high with the buprenorphine is very less compared to heroin or any other opioid drug. So that intoxication and sort of things will be less. So based on all these things, in a way, it will be, you can, like Dr. Lavanya said, that you can discuss on the principles of harm reduction. This is, there are two models, abstinence models and harm reduction model. We are going for the harm reduction model. And this might help you in preventing relapses over the next few months at least. And then based on the course, we'll take a call. So I think that was it. And otherwise, I think everything else was okay. I think else was went well. Yeah, this is how you have to do. I think no other extra precautions. Whatever you did is fine. Yeah. Overall, both of you. Yeah.
One doubt, sir, about this MET. So MET was not actually part of the original OSCE. So if the patient or the trained actor brings it up, can you say that, I understand that this is important and I would like to discuss this with you at a later date, and stick to the goal of the OSCE, or do you?
You can, like, that will be totally brushing aside also. Yeah, but as you said, I think you can't waste too much of time on that, because you'll have to speak about the buprenorphine thing now. So you can say that, yeah, that is also an important component of treatment, where we'll be discussing about other psychological treatments also. I'll be discussing it with you at a later time. You can say that. You can definitely say that. We'll be discussing about that also at a later time. But now, after this, first we'll discuss about the drugs, and then we can go to. You can absolutely say that. That should not be an issue. People have asked
yes. Shall I read out the questions?
Yeah.
So, how to pragmatically handle? Okay, so somebody said legal implications may aid in talking about MET. The legal consequences of substance use and other things.
Yeah, I think it doesn't come in the clinical encounter, because this is a clinical interview. We're entitled to confidentiality. So these sort of things definitely can be discussed.
Yeah.
That's an issue. Because otherwise, if you go take everything legally, then you'll not be able to treat any opioid or any other illegal drug patients with taking.
How to pragmatically handle the question which is commonly asked by patients about duration of therapy, sometimes saying that it is lifelong will scare them away.
I think this is for lithium. Okay, so yeah, in the first interview itself, that's a very practical thing. I think none of us tell in the first interview that will be lifelong treatment can scare them away, but actually that is the truth. So, but you had to prepare them for that, saying that it will be a long-term treatment. Depending on the course, we'll have to decide how long it goes. And like if multiple relapses are happening, we might have to consider lifelong also. So you had to prepare for them and say them that you have to talk about the risk-benefit analysis. If you, without drugs, the chances of relapse are high, frequent disruptions are in your life is high. So we have to think about something that keeps the symptoms at bay. So that's why we are thinking about long-term treatment.
Polysubstance may be inquired about. Consent before starting buprenorphine. In substitution therapy, weighing pros and cons literally with financial expenditure, as in terms of how much it costed to procure drug of abuse versus the treatment drug, can also help in MET, somebody suggested.
Yeah, that's a good idea. You can say that one of the harm reduction, because your cost and sort of things may decrease, an additional point. But I don't think you need not go into all these aspects, like whether you're taking other substances or motivation of the patient. I think that is not the focus of the interview, because here you're given with a very focused mandate. The person has whatever the vignette says, nothing more, nothing less. So I think you can start with that, and need not go into details about, because if you go on taking history, obviously 10 minutes won't be adequate. So
the substances mainly because interactions, if they use alcohol and heroin, things like that.
Yeah. So you can say that if at all you're taking other substances, that might be a risk and sort of things. You can explain that. But need not go into the details about full history and taking point of time.
Can words like withdrawal and craving be used?
Yeah, it's better to avoid. Withdrawal, people might understand, but craving also. But maybe it's better to explain it the first time you use it. Yeah, whatever we do say, but I think since this is an artificial atmosphere, it sometimes creeps up when you're talking, especially that the other person who you're talking to is a colleague rather than a patient. Sometimes it creeps up. Sometimes it happens, but it's better to avoid as much as possible.
What is the route of opioid use? The risks would vary according to that, and the patient needs to be informed and advised accordingly.
Yeah.
The patient's understanding of how he landed up in opioid use or dependence, and what is the stage of motivation.
Yeah, these are the things, as I said, I think we need not go into all these details. If you go into all these details, you'll not be able to focus on this thing. Right. So when we start the interview, we assume that you have taken all the history taking is over. Whatever details you have is what is provided in the case vignette. Now we focus more on this thing. And as you said, like for example, some important thing might be required for psychoeducation, like polysubstance use and sort of things. then you can use it, or route of drugs and sort of things. Then you can ask one or two things, but you need to go into all the details beforehand.
Another few questions, sir. How to assess for risk of patients starting to misuse or abuse buprenorphine naloxone?
How to assess?
Assess for what is the risk of the person misusing or abusing the medicine that is being provided.
Oh, okay. So assess for the risk in the sense that whether the person has, for example, like generally people use it through intravenous route. So if people with previous intravenous route might be at higher risk, and now
coming more frequently for consultations, requesting top up in medication in between, running out of medicines in between, a history of dealing. These would be some of the things.
Some history of previous antisocial activities and dealing and sort of things. These are some of the risks. But that is where naloxone helps you. Once you take it intravenously, it doesn't cause the high. It rather separates the withdrawal.
When to treat OP basis and IP basis?
That is not the focus of the current interview, but not for all OSTs. I don't think IP treatment is required. I think IP treatment is mainly required for the acute withdrawal phase and sort of things. It might be required. And for some patients whom you think there may be some risk of diversion, maybe some supervised sessions, you can give it over here. But apart from that, I think outpatient-based opioid substitution therapy is the norm. I don't know. I'm out of touch with that field for quite some time, but I think that is the thing. Am I right, Lavanya?
Yeah, I mean, it depends on the severity, comorbidities, substance, how, that's all. I think it's the same thing, sir. In introduction, can we say our name or just say I'm your doctor?
You can say your name. There's no harm in telling your name. It actually keeps you on equal footing. It's good actually to tell your name also.
Buprenorphine plus naloxone, any chronic pain syndromes / analgesics? I don't know.
Basically, they are asking whether naloxone, whether it will block those actions of other opioids. But I think naloxone orally doesn't work. It's
only when powdered and given IV. Should the psychiatrist even talk about how long the drug should be taken and how they plan and taper it?
Yeah, we have to talk about it. We can talk about it. This is a long-term treatment. This is you can give. I think in both in bipolar disorder as well as in the opioid substitution, it will be difficult to say a specific duration beforehand. Both are long-term treatments, and depending on the course of illness, we will have to take a call on how long we have to continue it. But at least we have to tell that it's a fairly long-term treatment.
Then they've talked about asking about reason for multiple abstinence, reason for relapse, motivational assessment, and to manage withdrawals, can we admit him and then start motivational process? Yeah, I think you've already addressed that.
Yeah, it's basically like Dr. Lavanya said, that depending on the listing, you have to admit the patient. Right. These are the things, right?
Yeah, these are the questions in this.
Okay. Yeah, I think all these things have been discussed. Okay, so I think we are already, I think we have finished the time. I think we'll not have time for other things. But anyway, first of all, I think thank you for both of you, Dr. Vijay and Dr. Manan, thank you for volunteering for this effort actually. And both of you did very well. So yeah, I think if you do the same thing in exams, it should be good enough, because this is what we have been doing throughout your residency. So you have to do the same thing again. So nothing to worry. And I think, as I said earlier, you can practice among yourself some of these scenarios. Whatever we discussed today, maybe you can practice among yourself and see. Okay. All the best.
Thank you so much, sir.
Yes, sir.
Thank you, Dr. Shyam and Dr. Lavanya. The last 1.5 hours plus was so quick. 1 hour plus was so quick. We hardly realized how the time flew actually. Though the scenarios were limited in terms of discussion, but it was a lot of enriching experience for anybody who's viewed it to understand the relevance of this sort of evaluation, how to set a context, what to be discussed, what not to be discussed, what would be the right information to provide in terms of patient's comfort, and also give a context of the whole diagnosis and all those issues were discussed. I think this is just an example, and it's a good practice to go ahead and do more such scenarios at your own levels. Also, make sure if nobody is available, you record your own video of explaining some matter to a patient. Review your recording very critically, because the patient in the current context could be in a corporate sort of setting. Their knowledge and understanding about illness and medication can also be there. They can be a real threat and challenge sometimes when you make decisions for them. So how much of information you're going to provide, and how you're going to take this sort of consents in the whole process of discussing and coming to a conclusion is all that's very important here also. And we will have more scenarios like this. This is just an example. I would like to thank Dr. Shyam and Dr. Lavanya once again, because they could generate such sort of scenarios. You don't have sort of question banks in Indian context to bank on. So we'll have to look at these sort of scenarios, multiply these sort of scenarios again at our own level to make sure we have template for discussion. Probably it's a good idea to make templates on what needs to be discussed about a drug, what needs to be discussed about diagnosis. And in a scenario like this, what is the best practice in terms of the context and introductions? I think it can be exhaustive. So they're given an example of how to go about. And thank you for the volunteers to actually demonstrate some sort of skills. It's a learning experience for all of us. All examiners in Indian context will have a similar understanding only. None of them have actually examined the students also on OSCEs format. So it's learning for both the examiners and students. So thank you once again. Thank you, Sriram, for offering this wonderful, seamless technical support to the whole process. Please make sure this sort of recordings are available, because right now Rajiv Gandhi University is having this theory examination. There's also circular to say that if patients are not available, it may be evaluated on OSCE format. So they may also have similar scenarios. So there will be a lot more people wanting to view after their theory is over. Is that okay, Sriram?
Yes, sir. Yes, sir. We have already been sending the YouTube links to all the participants after the program.
Can you put it as a channel, separate channel, and say that this is for OSCE so that they can go back and view everything at one?
Make it public. I'll make it public so that if they just search for OSCE in YouTube, they will get it.
Okay, perfect. Thank you once again, everybody. Looking forward to meet you again. One day we'll have one more series by Dr. Santosh Prabhu. Thank you so much. Good luck.
Thank you, sir.
Good luck.